All right, let's jump right in. If there's one single lab test you're going to order, interpret, and rely on pretty much daily in your career, it's this one, the Complete Blood Count, or CBC. You can think of it as the body's vital report card, giving you a crucial snapshot of a patient's health with just a few numbers.
And that's not an exaggeration at all. I mean, from a routine physical to a full-blown emergency, the CBC is an absolute cornerstone of diagnostics. It helps us screen for diseases, track how treatments are working, and figure out the cause of everything from a fever to just feeling tired. Honestly, understanding this thing inside and out is totally non-negotiable.
So here's the game plan for this explainer. First, we'll cover what the CBC actually is. Then, we're going to break down its three main cellular components, the red cells, the white cells, and the platelets. And finally, we'll put it all together to see how these numbers actually tell a clinical story.
Okay, let's start with the absolute basics. At its core, the CBC is basically a census of your blood. It's a head count of the cells that are doing the heavy lifting for oxygen transport, immunity, and clotting.
So it gives you a hard number, a quantitative look at these three cell lines. Are there too many? Are there too few? Are they the right size, the right shape? The answers to these questions can point us toward a huge range of conditions, everything from simple anemia to life-threatening infections and even cancer.
It's really amazing to think about how far we've come. Back in 1852, this was a 3-hour manual slog. Can you imagine? Today, thanks to something called the Coulter principle, which is still the foundation of our modern analyzers, we get these critical results in less than a minute. What a leap! First up, let's talk about the most numerous cells in our blood, the red blood cells, the RBCs. The best way to think of them is as the body's massive fleet of oxygen delivery trucks.
Their whole job, their entire purpose, is to pick up oxygen in the lungs and drop it off in the tissues. And that job is made possible by one critical protein that's packed inside every single cell: hemoglobin. No hemoglobin, no oxygen delivery. The trucks are running empty. It's really that simple.
Okay, this table might look like a bunch of alphabet soup, but it's your secret decoder ring for red blood cells. Just think about it in two parts: quantity and quality. The hemoglobin and hematocrit on top, that's your quantity. It tells you how much total oxygen carrying capacity you've got. The stuff below it, the MCV, MCH, and MCHC, that's all about the quality of the individual cells. Are they the right size? Do they have enough hemoglobin packed inside? And finally, RDW tells you about the variation in cell size, which is a huge clue that the bone marrow, the factory, is under some kind of stress.
All right, here's a clinical pearl you will use constantly. I mean it, every single day on the wards. The rule of 3. Your hematocrit percentage should be roughly 3 times your hemoglobin value. So if you have a hemoglobin of 12, you expect a hematocrit right around 36. If it's way off, your first thought should be, is this a lab error? But it can also be a real clinical clue. For instance, in severe iron deficiency, the cells are so small that the hematocrit can be way lower than you'd expect. It's a fantastic little sanity check.
So clinically, this is where the rubber meets the road. Low levels or anemia mean the body is being starved of oxygen. Your patient is going to feel fatigue, shortness of breath. High levels, polycythemia, now the blood is getting too thick, almost like sludge, which raises the risk of dangerous clots. This can be from something simple like dehydration, or it can signal a serious bone marrow problem like polycythemia vera.
Okay, so while the red cells are busy making deliveries, a totally different team is on patrol looking for trouble. And these are the white blood cells, or WBCs, the soldiers of our immune system.
The total WBC count tells you if the army's been mobilized, but the real story is in the differential. That's what breaks it down into the specialized units. Neutrophils are your bacterial first responders. If you see a left shift with lots of immature neutrophils, it means the body is desperately pumping out new recruits to fight a bacterial infection. Lymphocytes are your viral specialists. Monocytes are the heavy-duty cleanup crew. And eosinophils and basophils are key players in things like allergic reactions and parasitic infections.
So when you look at that total count, a high number, leukocytosis, usually points to infection, but you have to always keep leukemia in the back of your mind. Always. On the flip side, a low count, leukopenia, is incredibly dangerous. It means your patient is immunocompromised. They're vulnerable to everything. You're going to see this all the time in your patients on chemotherapy.
And finally, we have our third major player in the CBC, the platelets. Think of these guys as the body's emergency repair crew, rushing to plug any leaks in our blood vessels.
These aren't even really full cells. They're just these tiny little fragments that circulate around, basically on standby, just waiting for a signal that a vessel has been broken.
When that happens, they activate, they get all sticky, and they form a plug to stop the bleeding. They're the first step in the whole clotting cascade.
And just like with everything else in medicine, it's all about balance. Too few platelets, thrombocytopenia, and your patient is at a huge risk for uncontrolled bleeding. You'll see this a lot in sepsis or as a side effect from drugs like heparin. Too many platelets, thrombocytosis, and now you're worried about the exact opposite problem. Dangerous, unwanted clots forming where they shouldn't be.
Okay, now for the most important part. A CBC isn't just 3 separate lab tests. It's a single integrated story. As a clinician, your job is to see the patterns, to connect the dots.
So let's use a clinical scenario you will definitely encounter: sepsis. Sepsis is a true medical emergency where the body's response to an infection just goes completely haywire, causing widespread damage. And the CBC gives you some of your first, most critical clues.
In sepsis, the CBC starts to paint a very characteristic picture of total systemic distress. You'll see sky-high neutrophils as the body throws its first responders at the infection. But at the same time, the lymphocytes often crash, and that's a grim sign that the immune system is getting overwhelmed. Platelets plummet as they're used up in all the chaos, and you'll even see the red cells get affected, with anemia developing and a rising RDW. This whole combination, high neutrophils with low lymphocytes and platelets, that is a massive red flag for sepsis.
Okay, let's interpret this report just like we would on the wards. First thing you notice, hemoglobin is low. So, boom, we know the patient has anemia. What's the next logical question? What kind of anemia is it? So you look at the MCV, it's low. That tells us the red cells are small or microcytic. The low MCH and MCHC confirm they're also pale or hypochromic. Small pale cells, that is the classic fingerprint of iron deficiency anemia.
And while our automated analyzers are incredible, never ever forget the power of just looking at the blood itself. A peripheral blood smear lets us actually see the morphology with our own eyes. Are the cells sickle-shaped? Are there schistocytes that suggest a hemolytic process? Or are there blast cells that scream leukemia? The numbers give you the what, but the smear often gives you the why.
The CBC is such a powerful and enduring tool. But it's not standing still. As we start integrating AI, advanced flow cytometry, and new parameters, this simple blood test is only going to become more and more predictive. It really makes you wonder, right? What life-saving information are we going to be able to pull from a single drop of blood in the decades to come?